Hi, everyone. Welcome to this episode of the Yoga Happiness Podcast. I'm Burgundy Michelli. In this interview, I talk with Dr. Charles von Gunten. He is the Vice President of Medical Affairs for Ohio Health Hospice and Palliative Medicine. I met with him at the Kobacker House, which is the inpatient space for hospice in the Ohio Health Network. The Kobacker House is off of Olentangy River Road in Columbus, Ohio, very near the Riverside Hospital. As I drove in, I followed this lovely winding path to get back to the facility. There were signs for watching out for deer, and I was reminded definitely to take it slow. There's a walking trail that goes all the way around this space, as well as waterfalls and serene places for sitting and watching nature and feeling like you're a part of nature. Dr. Von Gunten's executive assistant, Paula, gave me a little tour while I waited to start the interview. And she showed me the chapel that's open to all faiths and pointed out that the deer that are in the forest in the surrounding woods frequently walk up to the bushes on the outside of the patios just next to the patient's rooms and nibble on the bushes. And that gives these patients a way to still feel close to nature and a part of nature. As many of you know, my mother passed away from dementia or primary progressive aphasia in September of 2017, so not too long ago. In her last several months of life, she had hospice care. I can't say enough good things about the hospice team that worked with my mom and with me. I highly recommend anyone that's in a similar situation to get set up with a hospice team. These people know, they're professional. They know how to help you grieve, and they know how to help you handle this. They were there, as they told me, they're there for the quality of life of my mother, but also for me, because this is hard stuff. From a yoga standpoint, I see this, using a hospice team, talking with the hospice nurses as a form of self-care and self-compassion, as well as the care and compassion for my loved one, for my mother. The hospice folks can help you with those feelings of compassion and grief and all the other things that you might feel. And also, for any of you that might be interested in, you might be trying to figure out your path in life, perhaps consider a career in palliative medicine. If you enjoyed taking care of people, don't forget about this aspect of care. Good people just like you are needed in this kind of an environment. So I hope you enjoyed this interview with Dr. Von Gunten. He's such a wonderful man, and it was very much a pleasure to talk with someone who has such a passion and compassion for the area that he works in. I really enjoyed the article that you wrote that was entitled Optimism from 2017. Was that an article just for like a publication, or was that actually a speech that you gave? That optimism?
That was written as a written piece.
Okay.
But it's a theme that I've visited throughout my career, and perhaps why it resonated is because it's authentic.
Yeah. It did, and it surprised me that when I saw this written by a doctor, I expected this to be a little bit more steeped in medical terminology and things like that. And I did find, this is this man writing this very open, honest story about how you found palliative care. I really enjoyed that, and it was neat to see how you came to that, because that was going to be my first question to you, and then I read this and I'm like, well, that answered my question. One of the things that I found interesting about that article was towards the end when you talked about how you don't feel that palliative care should be necessarily a specialty that you should be ashamed of. Why do you think that people have somewhat of an opinion of doctors, people that work in palliative care or hospice?
Many people, when they think of hospice care, and when I say people, those who are not engaged in healthcare, don't have any experiences other than what they've had in their own families or what they read in the newspaper. And they think of sadness, sometimes fear, sense of loss, failure. What many then discover when they have their family member cared for by a hospice program, or they work there, and now the growing number of physicians who are essential parts of hospices find joy, deeply meaningful work, making a huge difference in the lives of others that others would have thought impossible. Laughter, the best of human nature, love, heroism, bravery, long-suffering, selflessness, things that most don't find in day-to-day life, and yet in a hospice program, it's routine every day. You see the best of people in those that you would have never thought it possible. Well, how could you not be optimistic about our ability to help those who are suffering, and the ability of humans in the context of their families to not just cope, but to grow and develop and find parts of life that they hadn't savored in that way before?
Death can be scary, but it happens to everybody. And it's interesting to me that death and the process of dying is seen as somewhat taboo, and we have to hide it away, and we don't talk about it. We're afraid to make people upset by either our situation or a family member's situation. But truly, I wonder, in your experience with working in the hospice environment, do you sometimes find that people that maybe family members don't feel the right to feel joyful when their family member is dying?
Those are all great questions. The death, particularly death from after a long illness, where it's not sudden, where there is time. Everyone's on a journey, including the patient. And by and large, the patient is further ahead on the journey than loved ones, whether it's spouse or family or relatives or friends. And so you get to see everyone on that journey at their various places. For those who've never had an experience, which for all the reasons that you described is common, the initial reactions are fear, avoidance, denial, which is such a useful human coping strategy. But when it's done in the context of having enough time with people who have experience, and look at a patient as a whole person with physical, emotional, social, and spiritual dimensions, and as an integral part of his or her family, and a family is not just of biological connections, but who's close in love and affection, the fear goes away. Because fear is usually a fear of being annihilated, fear of being overcome, fear of not being able to cope, of failing. And when it's now, oh, well, this is what happens. This is the normal. This is usual. This is what we can do. No, there are no rules, or the rules you used to live with. Well, we don't have to use those rules anymore. Oh, isn't that fun? Most people remember as children when you were outside the rule. It was fun to color outside the lines. It was fun to not come in from recess. It was fun to eat ice cream sundaes for breakfast, lunch, and dinner, and nobody crab at you. All right, so that creative, being able to focus on the important things, fear tends to go away as long as there's someone there that has confidence, can guide the way, can offer choices that can help it be customized while it's safe and effective, that's when fear drains away and is replaced by those more positive human characteristics. The other thing I would observe, which is also a feature of human nature, is despite all the aphorisms for thousands of years, appreciate every day, that's not normal human existence. But when time becomes short, then it becomes precious. So that savoring every moment. The sky has never been so blue. The children have never been so loving. The dog has never been so cuddly as when you know that time is short. So this heightened awareness, the mindfulness of being in the moment and not worrying about yesterday or tomorrow, just the moment, that happens much more routinely in the period, in the days and months before death as it does in the years and decades before.
I assume that you're talking about you and your staff when you say that people are able to sort of drop that fear when they're guided by somebody who can help them understand these things. And who are those people that you're referring to then?
In the United States, the hospice model of care provides a team. Doctors, nurses, social workers, chaplains, nurses' aides. In addition, equipment, supplies, medicines are all provided. Medicare pays 100%, there's no copay. So when you have an experienced interdisciplinary team that meets the needs in the physical, emotional, practical, spiritual dimensions, and when we used to say medical care, we meant all of that. The practice of medicine was taking care of a whole person. It's only in recent decades that has been diminished to some sort of a technical specialty, and the rest of it is non-medical. There's nothing that makes me angrier when somebody says, "Oh, it's so nice to see all this non-medical care." No, it is all medical care, but medical care of the whole person in the context of his or her family. Now, the reason for a team like that is very intentional. Each of the standard disciplines, doctors, nurses, social workers, chaplains, volunteers, nurses' aides, physical, occupational, speech therapists, have their own body of knowledge and their own specialty and their own way of looking at things. To have a team like that around a patient and family, well then, like playing an instrument with many keys. All right, which keys are played with what intensity depends on the patient and family, and it changes over time. The nursing, which is the bedrock discipline of hospice care, the core of of nursing is being with, of helping, guiding, informing, sharing the emotion, and as a way of discerning, all right, what's most needed. Physicians trained very differently to think critically, put them in the context of all the other diseases that can happen, the medical therapy, particularly symptom control, social work, looking at people as they're the experts in family systems. So, which tends to be what nurses, doctors tend to fail, because our careers are focused on individuals, but family systems, and everyone who's in a family tends to smile and like, oh yeah, let me tell you about how my family works and the rules of our family. And when someone is sick, that challenges the rules. Families behave in certain ways in response. We need somebody to interpret it, help guide it, so that most people agree that their family is dysfunctional. And that's another word that doesn't really belong. Every family functions. Just families function differently.
Right.
And when they're stressed, they respond. Well, you need somebody to help. All right, this is the pattern. This is what's needed. We need this and this and this to happen in order for the family to be able to pull together and to survive the death of the member. And then chaplaincy, of course, the core discipline of a chaplain is not religion.
Right.
It is witnessing the spirituality of an individual in the context of their family. That ability to be with without trying to fix. Well, doctors and nurses are fixers. Social workers would say they're not, but they also try to fix. You need somebody who can accompany and let be and guide people on their own journey. And particularly in the U.S., where religion may be a part of someone's spirituality, it frequently plays a role, but sometimes it's actually caused harm. It's caused damage. There's been spiritual wounding. All right, you need somebody who has facility with that to guide the team as well as the patient and family along that course. Pharmacists who understand the medications and the combinations, particularly used in doses and schedules that are not typical in the rest of healthcare. Our ability to relieve suffering is more powerful now than ever in the history of medicine. The challenge is to make that knowledge available to the patients when and how they need it, and that's the reason for the specialized knowledge of chaplains on the teams. And then the nurses' aides are sometimes the ones who have the most intimate knowledge of patients and their families. They're involved in bathing and in personal care. Deep, loving relationships develop. That sense of when you're without clothes in the company of somebody who is touching you, whether it's applying lotion or bathing you, well, intimate times lead to intimate conversations, intimate knowledge. Our nurses' aides find such reward at being able to be intimately involved with patients and families and given that sense of closeness. So when all these people are bringing their skills together, chatting among themselves, interacting with patients and families, magic happens more often than not.
It's interesting to me that, so from my own personal experience, my mother passed away in September of last year, and from a long trip with dementia. And honestly, I had a wonderful experience because of the hospice team. And it's weird for me to say that I had a wonderful experience during my mom's dementia and her dying. And one of the most amazing experiences to me that was like, I had to sit there and think about it, was when one of the nurses' aides was bathing my mother and just the care she took. And like, I'm sitting there in front of my nude mother and all of a sudden I'm like, this is a beautiful experience. And I'm like, why am I saying that? It's such a foreign feeling, and then now the smell of the cocoa butter lotion that the woman put on my mom is now a wonderful smell that I attach with the beautiful death of my mother. What a bizarre thing for me to feel and say, but that was because of the experience of the whole hospice team.
Right. So you illustrate so much of what's common. There's a social, I mean, we all know in our culture what the rules are. I love the definition of culture is the way we do things. It's a series of unwritten rules. And you perceived, all right, I'm not supposed to be happy or pleased or find this delightful that I'm taking care with this hospice of my dying mother, but yet that's the emotion. Do I suppress it? Should I talk about it, or do I keep it a deep, dark secret? And when I'm around other people, do I have a long face because that's what they expect?
Right.
And I'll upset them if I have a spring in my step and say, I had the most beautiful, intimate experience today with the nurse's aide who was giving my mother a bath and she's close to dying. All right. Standard American culture that values youth, beauty, perfection, and particularly now, that if anything bad happens to you, well, it's your own fault. It's your thinking, your karma, your whatever God, your relationship to God isn't right unless you're really happy. So having to deal with that as a loving daughter with all the role reversal. My mother is my mother. She's also like an infant in front of me. I'm now the mother.
Yeah.
that jumble, when people support you, hold you through that, then life has a special, it's a different glow.
Yeah.
It's a different sense of what's meaningful in life. What's important to know, that's not a unique experience.
Yeah.
Everyone on this journey can experience that if you have the skilled people and if you're open to it.
So I'd kind of like to make a little bit of a jump in a different direction. One thing that I am interested in, because of my experience with the wonderful staff that turned into family for me, the nurses there, is this is hard work for you guys. This is emotional, physical, all of that. I mean, just from an emotional standpoint, towards the end of my mother's life, these nurses were trying not to cry in front of me. And I'm like, ladies, you've been more of a family member to her than I have. Please do cry. And from a physical standpoint, I would imagine that the gals that were working on, when I was told it's not called flipping her. She's not a pancake. When that was what the nurses had told me. She's like, honey, we don't flip her, we're turning her. But I mean, that's physical work, moving a person's body and things like that. So is there something in place for the staff, those caregivers, to take care of themselves in all of this?
So the short answer is yes. The more extended answer is all the stresses of doing hospice work, they're real. There's related to nursing that you described, and that's true for nursing anywhere. One of the biggest reasons nurses stop nursing is because of the physical labor of it. After a certain age, it's harder and harder, the muscles, the joints, that sort of thing. So there's that real work. But what people in hospice care would say is, because it is required to be set up as a team, and you are required to talk about every patient in a group on a regular basis, the time to talk about patients and families, including the losses, because love and loss is a daily experience. And you're absolutely right to use the word love. Tender loving care is at the heart of healthcare. It's what gives health professionals of any discipline joy in the work. And in hospice care, it's more on offer. You're more able to do that than almost any other branch of medicine. That's intrinsically very rewarding. But then the cost of love is sadness.
Yeah.
Right? It's not indifference. It's not hate. The cost is sadness. So a place to be sad where it's not judgmental. Again, American culture, tears generally, and I come from a WASP background, and so, that's just not done. All right, but that's a barrier. You have to be in a place where it's safe to cry or to otherwise emote, because you form relationships, they're warm, they're deep, they end, and then you go on to the next patient. So building in that time, building in that personal resilience is a core thing that good hospices help cultivate in their staff. But it's as real as what's the patient's pain score, what are they taking, what's their family situation, what's their spiritual assessment, what's the team's, how are people doing on the team. And consequently, the emotional burnout rates among people doing hospice care is among the lowest in healthcare.
Really?
Yes. It's not what you would expect, because there is attention to this. It's out in the open, in contrast to, say, the standard hospital, where suck it up, buttercup, move along. There'll be no tears. You will no personal attachments to the patients, no unprofessional.
Yeah.
That's much more of a setup for emotional burnout than working in hospices.
So do you think, and this is actually one thing that I was thinking of when I was reading your article, is there a way to actually take the the way that hospice and palliative care is built and apply that to the rest of medicine?
So I think so. Most of the people I know as physicians working in this field have that view. This is a powerful way of taking care of people who are sick. And I frequently frame it as, why would you bottle it up and save it only for the people who are dying?
Yeah, right.
If it is effective, and it was first developed around people who are dying, you take those elements and then you apply it elsewhere and see where it works.
Yeah.
So that I view the growth and development of palliative care as, although it grew and developed out of hospice care, it's developed far beyond the reaches of end-of-life care. There are some recent studies, particularly in cancer, that have been the most striking, where in randomized clinical trials, which is that's the gold standard for discovering new aspects of medicine. If you take a group of people with advanced lung cancer and half of them get palliative care woven in with their curative treatment, they're getting chemotherapy, they're getting radiotherapy, they're getting surgery, and compare that with the group that gets it with palliative care and without. The group with palliative care, not only do they have better symptom control, better coping, less pain, they live longer. They live 30%, 50% longer. And they get less chemotherapy, less radiotherapy, and yet they live longer. It's been sort of cynically remarked that if it was a new drug that produced these kind of really remarkable results, it would be a $10 billion drug within a year.
Right.
Because it's not a drug, it's a group of people working together in the way I've described. But when the goal is to cure the cancer or put it into remission, it works as good or better. Mm-hmm. It's now being applied in bone marrow transplant. I developed a program of palliative care in a NCI-designated cancer center where the bone marrow transplanters you were never doing transplant for palliative purposes. Your goal is to cure the underlying cancer. And they would say, we couldn't do transplant without palliative care. Controlling the symptoms, the stress, the helping the families get through that. More people get through the treatment with less complications by having it combined. So do you see where we've taken something that's gone from taking care of the dying very close to the time of death, learned what the principles are, and then applying it earlier and earlier in the course of illness. And that's where I see us now in American medicine. All right, how far, where does it make sense to combine it? Should we be combining this in heart disease and in neurological diseases? Those are the things that we're exploring here in our program development. Mm-hmm. The other is, and healthcare, once you find something that works, you want to do it systematically. So I like the analogy. All right, once we discovered that penicillin cured community-acquired pneumonia. Community-acquired pneumonia in the 1920s was fatal 70% of the time. Now it's fatal maybe 10-20% of the time. The difference is penicillin and it's the drugs that have come after. And now it's a quality issue. All right, if you had did we diagnose the community-acquired pneumonia? Were they treated in a timely fashion? Did they get the full treatment? And you would say, of course, it's now. Well, the same should be true. The science is so clear that hospice care produces the best end-of-life care. So now it needs, all right, every expected death then should occur with hospice care if we are going to maximize quality. Mm-hmm. It's not a choice any more than offering antibiotics for community-acquired pneumonia is a choice. There is a best practice. Patients can accept or reject medical advice, but we would argue pretty strongly if you have a simple community-acquired pneumonia, the antibiotics will make you better. Let's work through your objections the same should be true for enrollment in hospice care for the last months of life.
Mm-hmm.
It should be the standard of healthcare, and anything less is viewed as a miss, and we should do the quality improvement approaches that we do in every other aspect of healthcare.
Mm-hmm. Can you explain to me exactly what palliative care is?
So palliative care is an added layer of support to the care of a patient with a serious illness and their family.
And it's always with serious illness.
In general, as a specialist service, as a specialist team, yes. If we go back to this approach to care was developed for cancer patients who were in the last months of life, and it worked. All right, well, if we take out the last months of life, but it's a team approach, patients, their physical, emotional, practical, spiritual dimensions, and now we're working alongside the patients, other doctors, other healthcare professionals, their primary care doctors, their cardiologists, pulmonologists, nephrologists, others, working together as a team with the palliative care approach focused particularly on comfort, quality of life, which is what most people want. They don't want to forego medical treatment if it will work, but they don't want to be uncomfortable. They don't want it to wreck their families. They want to be able to cope. So it's bringing that together, an added layer of support to the patient and family, working in conjunction with standard healthcare.
It does seem like that could be something that could be applied in a lot of places.
In the surveys that have been done among Americans, when it's explained this way, there isn't anybody who doesn't want it. It makes sense. Too many people hear the word palliative and they think, well, that's just a synonym. Either they don't know what it means, or they think it's a synonym for hospice care. And because much of hospice care in the U.S. is given in the last week of life, it means you're going to die quickly. And some people, because they see as soon as someone's enrolled in the hospice and they die in a week, well, the hospice must have killed them.
Right.
So this sense of, oh, got to stay away from that, please, not the palliative care. Mm-hmm. I'm not ready for it yet. It's because of a misunderstanding, because of those associations that they've observed.
So hospice is a form of palliative care, perhaps?
I would say all hospice care is palliative care.
Okay.
But not all palliative care is hospice care.
Got it. Okay. I'm interested in the fact that you chose palliative care, the hospice world. Did you, prior to this big aha moment and all of that, how much time did you actually spend on the other side of medicine, in other specialties?
My career started with a PhD in molecular biochemistry, and then medical school in a research-intensive, top-tier medical school, going on to a residency in internal medicine, again at a top-tier medical center, and then to specialty training in medical oncology, because it's a fascinating field. But so I'm a card-carrying, scientific basis, hardcore doc through the whole way.
You've got a lot of letters after your name, too.
I do, and part of that means I'm old. But yes, I've been through the traditional medical scientist training approach and practiced in all those settings. So the reason for the path I took was in medical school I was exposed to hospice care. It was part of the curriculum. I was fascinated by it. Because they didn't offer a clinical rotation, I wrote the curriculum for the first one and was the first one in my fourth year. Although it wasn't the reason I chose where I went for residency in internal medicine. There was a hospice there with a hospice unit. And the real aha for me came in my internship year when you're admitting patients throughout the hospital, and we admitted patients to the hospice unit. I didn't know it, but that's what we're doing. And I was so struck. The care was different. It was better. because there was no difference in the patients. I was admitting the same patients elsewhere in the hospital, 700-bed large urban hospital. But on this hospice unit, I remember distinctly meeting somebody for nausea, vomiting, dehydration, and I was, saw the patient, writing the orders, and the nurses said, well, Dr. Von Gunten, why do you want to get those laboratory tests? I said, because I was an intern, because that's what I do.
That's what you do.
Someone will be very mad at me in the morning when they ask me about this admission and I can't tell them the results of their sodium and their potassium and they said, well, here, if it won't change what you do, there's no reason to stick them, and she's tired. She wants to sleep. Mm-hmm. And I notice here you've written orders for hydration, which is fine, and we can do that. But we don't. You think she's dehydrated based on your exam, correct? Yes. Well, then let's do that. And you've written down here for a chest X-ray. Will that change your management? Well, no, but admission to the hospital means you have to have a chest X-ray, and it's fine to get it, but she's not getting it tonight. She needs to sleep. She can get it in the morning. Will it change anything tonight? No. Well, then she's getting it in the morning. Well, I just thought that was wonderful. Challenging the norms, being very patient-centered. Yeah. Why are we not doing this elsewhere in the hospital? Mm-hmm. And that was the reason consult services developed, and I developed our own consult service, one of the first, to bring that knowledge to everywhere else in the hospital, whether it's the recovery room or the surgical suites or ICUs. And it has grown like wildfire over the last 25 years because it's good medicine.
Mm-hmm. Do you, I don't know if there are any statistics or studies on this. I'm very aware of the concept of burnout for doctors. Mm-hmm. Do you know if doctors in your line of work versus other specialties, primary care, whatever, do you know if you guys have lower burnout than other folks?
The data I've seen is the burnout rate is lower. But there's something very important to know about burnout among physicians in general. Most people assume that burnout is from the emotional toll of doing the work. So, for example, in hospice care or palliative medicine, you're seeing all these sick patients who have distressed families, and isn't that emotionally exhausting? And the answer, of course, it is. And you develop emotional hardiness. But when you look at burnout and what its root causes are, it turns out it's not the patient care. Mm. It's the business of healthcare. It's the operational details. Is the electronic medical record that you're using, is it easy to use? Mm-hmm. What's not, even though the whole country went to electronic medical records, it doubles the amount of time a physician needs to spend at a computer, and no doctor went into medicine to spend more than half of his or her day in front of a computer screen. Mm-hmm. How is it scheduled? Are there enough people to do the work that's at hand? Is the schedule fair? Do I have a say in how my work life is? Those are the sources of burnout rather than the emotional burden.
Now, you don't have, I don't know how your schedule works. You don't have the same kind of requirement to cram and jam your day with 10-minute appointments, do you?
Correct.
Yeah.
So the in part because it's a new specialty and it's a team, the volume of patients is much lower, because a standard initial encounter with a patient and family, whether it's at home or in a hospital room or in an ambulatory outpatient clinic, is an hour. And that usually includes time beforehand gathering information as well as time afterwards. So it's more like an hour and a half or two.
Wow.
For a single patient case.
Wow.
Now, it turns out that there are ways to code and bill for that. The Medicare covers it, Medicaid covers it, various insurances vary in what they cover. But it still needs to be organized in a way so you can do the care and not be distracted. So I would say probably the biggest source of frustration among my physicians here is pre-authorization for medications.
Oh.
This person needs morphine, but I need to get that approved. I need to spend time on the telephone, mostly on hold, talking with someone who cannot even pronounce the word, let alone know what it's for, and ask me a series of screening questions for whether or not the insurance company will pay for it. Yeah. Now that is soul-sucking. But related to the subject of burnout, it's those things that are there that people, physicians among them, need to have a sense of control over their lives and a sense of control over what they do and how they do. It has to be meaningful and important. Yeah. And there has to be sincere efforts to reduce the useless activities so that can favor the useful activities where the physician or others feel like they're doing meaningful work.
Do you actually enjoy your job?
Oh, I think I pinch myself, and we now have 28 physicians.
Just working in Cobacher?
No, working in the program here across Ohio Health, and it needs to double. And that's just the physicians. Nurse practitioners, we have 23. That will need to double. Social workers, chaplains. So we're on an intense growth path here. But when everything works well, every one of them pinches themselves and says, "Oh, I would do this job even if it were for free." And that's the core of professional satisfaction. That I can't imagine doing anything else in the world but this, and that's who we look for.
That's great. If only more people could feel that same way about what they do.
I'm aware that what I mostly see reported in the papers, that the vast majority of American workers don't have that experience in the jobs they do, and I'm sad for them. It's one of the joys of working in healthcare. It's a joy of working here at Ohio Health, where there's an intense focus on having the healthcare workforce be happy and enjoying their work. The CEO, Dave Blum, would say that he has executed on a very specific formula, and it's in our mission, where people like to work is first. He would say that comes first, because if you do not have a happy workforce, you can't do good healthcare. The second is where doctors want to practice. And he would say, well, if you don't have a happy workforce, you won't have happy doctors. And then the third is, and most importantly, where people want to get their care. So in his view, you get happy patients getting best care only if you have happy workers and happy doctors. So that's his formula. One would say Ohio Health has been very successful in every way. And that's not a secret formula. It's sort of right out there. He talks about it when people ask how has he achieved what he's achieved. He would say it starts with that.
I'm gonna leave it right there, because I think that's a great way to end it, and I'll let you get back to your day. I appreciate your time.
Thanks for your interest.
Thank you again to Dr. Charles Von Gunten for his time and his honesty and just his overall good humanness. What a great man. I do want to thank Dr. Nan Alkire. She's the one that suggested that I even reach out and try to set up an interview with Dr. Von Gunten. Thank you to Paula, Dr. Von Gunten's executive assistant, and to Marcus Thorpe, Ohio Health's media relations senior consultant, for helping me to get this interview set up. If you liked this, please click like or subscribe. And check out my Patreon page, patreon.com/yoga happiness. I typically have extra details and information regarding my videos and my posts on my Patreon page. Please consider becoming a Patreon patron. That will help me to continue with these interviews, perhaps get better equipment, and continue providing educational information, videos, and so forth. I just really enjoyed doing this. I'd like to give a big shout out to my current Patreon patrons, Chris, Nancy, Lauren, Athne, Vince, and Jeremy. Thank you so much for your support. It makes my heart feel full. Like I'm just bursting. Thank you so much. And to everyone, enjoy your week. I'll talk to you next time.